Hello and welcome to Perez Prosthetics Continuing Education Webinar for Physical and Occupational Therapists in Ohio and Michigan. We are thrilled to have you here and appreciate your commitment to furthering your skills and working with the amputee population. Now, before we get started, let's go over the steps to receive your CEU certificate. First, please make sure to watch this video in its entirety. Once you've completed it, click the link in the description below to access the online quiz. After taking the quiz, send an email to the address provided in the description to let us know that you've completed the course. We'll then send you your certificate of completion along with a quick survey for feedback. If you have any questions about the material or the process described in any specific webinar, never hesitate to reach out to us at the same email address, or you can visit us at perryprosthetics.com. Thank you for joining us. We're excited to share this valuable information with you.
And get started. Thank you guys so much for taking time out of your day today. I really appreciate it. This is kind of the launch of our webinar series. If you have attended the last couple, I appreciate you coming back. If you are brand new, my name is Theron. I work with a company called Perez Prosthetics. So I'm going to introduce you guys. This is Mike Schroeder. He's our upper extremity prosthetics specialist. He's going to be leading the majority of this presentation today. And then Michael Perez, he's our clinical manager. He's actually going to be talking a little bit more about the evaluation process here soon. So Mike, you want to give yourself a little introduction as to who you are and what your role is here at Perez?
Yeah, absolutely. So as Darren mentioned, I'm the clinical manager. I help oversee all the clinical staff. Me and Mike Schroeder work very closely together on all the upper patients, the whole process, which we're going to be diving into throughout this presentation, is very involved and we kind of teach every patient that that's very much so the case. They never walk in and just walk out with a prosthesis that day. So I'm very involved throughout the clinical process and setting those processes for the entire clinical team. We do have a custom fabrication lab here as well on site that I oversee as well, or at least help with the scheduling and ensure quality outcomes. So yeah, I'm involved in a little bit of everything here at Perez Prosthetics, but definitely the clinical outcomes and the care that our patients are getting.
Perfect. And Mike, I'll let you kind of introduce yourself briefly and what you do here.
Okay, I'm Mike Schroeder. I'm the upper extremity specialist with Perez Prosthetics. So any patient that is an upper extremity amputee, I would see all of those patients in any of the offices that we have, which would be Findlay, Perrysburg, and Ann Arbor.
Look at him transitioning into my slide. It's like you knew it was coming. He's a pro. So for those of you who are maybe new to Perez Prosthetics, we are a family-founded company. We get to celebrate our 25th anniversary next year in 2025. Just like Mike said, we have offices in Perrysburg and Ann Arbor, Michigan, and then also Findlay, Ohio. Proud to serve those communities and the surrounding areas as well. What you're experiencing right now is our CARE program. It's our education platform where we get to share our knowledge with you guys, but then ultimately learn a lot from you. We cannot do our job without the PTs and OTs who serve our patients. And so we very much appreciate your devotion to our education program. We like really cool technology as long as it's appropriate for our patients. We do not fit patients with things that, number one, their insurance wouldn't provide to them, which you'll learn a lot about here. And number two, things that wouldn't be appropriate for them. So while we believe in the best in state-of-the-art technology, only if it's suited for our patients. And then outcomes. Outcomes are number one, and that actually transitions into the next slide. You guys know what the objective is. You got it when you guys signed up for this course. But our 4 pillars for education, and this is across any presentation that we do, is patient safety, patient satisfaction, efficiencies, and then ultimately outcomes. Outcomes is number one in our book, and we love sharing those outcomes. So I do invite you to check out our YouTube channel. Once you're done, you can see a lot of really cool patient success stories, and then share those videos with future patients to kind of show them what life's going to look like on the other side of that bridge. So because you are slightly, and I only mean slightly shorter than me, I'm going to tip that and I'm going to scoot that over just a little bit so you're a little more front and center. And then Mr. Perez, if you would like to kind of let us know what's involved with the initial eval, and we'll get started.
Yeah, absolutely. Thanks, Darren. So this is essentially one of the first steps, if not the first step, with providing care to our upper extremity patients. And this evaluation can happen either prior to the surgery or after the surgery. It could happen in our office. It could happen in front of OTs. It could happen, possibly even in some different hospital settings or skilled nursing facilities. So we're pretty flexible in where we're going to be seeing the patients at for this initial evaluation. But essentially, this is the formal process of creating a treatment plan of what is the best device or devices for this patient. And we're going to be gathering a lot of the information that you see in front of you on the slide throughout the appointment, largely making sure that what we're providing to the patient is going to fit them, their lifestyle. And we definitely have to take into account what insurance do they have? Does their insurance cover the devices that we think is best for them? And obviously throughout this process, we're working very closely with the team. And I think that's one thing that helps, make us and Mike as the upper extremity specialist kind of, a little bit more unique in how we approach the care for these patients. So he's going to work alongside OTs and he's going to utilize the information that they've already gathered and have worked on throughout therapy and what does the range of motion look like for this patient, to kind of make sure that we're fitting them with what's going to work best and what are the goals for this patient as well. So at the end of this evaluation, we're not only determining what is the device that best fits the patient, but also we're going to start putting things together that we're going to be working on in the background, such as our documentation, working alongside the doctors and the therapist on gathering those clinical notes, putting together the treatment codes that we know that we have to submit to the insurance to get the authorization so that we can get this device approved and begin the actual fitting process and providing the device to somebody. But I'd say one of the biggest things, and Mike can weigh in here on as well, that we focus on is what are the current mobility of the patient, or what are the activities that they were doing prior to amputation, and what are the long-term goals of what they want to return to doing in everyday life and as well as work. Those are two very key factors that kind of play a role in us creating a treatment plan, or again, kind of selecting that device for the patient or determining what's best for them. And there's a lot of variables that play a role in it. As you guys all know, as therapists, you guys do an evaluation yourself and kind of orient some of these things off of their goals and the feedback from the patient. So we focus in a very similar manner.
Perfect. Anything to interject there?
No, I think that's all good.
Okay. Actually, I will ask a question because a lot of these attendees attended our successful patient outcomes presentation and then also the suspension one, where we talk a lot about K levels. And we did mention in the last presentation, there are no K levels when it comes to upper extremity, correct, Mike?
No. I mean, it really comes down to what the patient goals are and what they did before and what their insurance is willing to pay for.
Gotcha.
One thing that I'll throw out there and interject even further on, and this is going to be maybe a good transition for the next slide. I mentioned early in that slide that sometimes we're seeing these patients for the evaluation prior to surgery. In those cases, that's great because then we can sometimes work again alongside the doctor and the therapist and determine, what does the patient present as and what are the options for amputation in terms of the location of where that amputation takes place, because that can completely change the landscape of what does prosthetic care and treatment mean for them.
Perfect. Look at these guys are just natural. These are people who looked at the slides ahead of time. I'm telling you. All right, Mike, take it away and we're going to talk about amputation levels.
Okay, so what Mike was just getting at there was that's what this slide here was put together for, was to help the docs determine if they get the option where to amputate. We were doing an in-service somewhere, and it was for some
residents,
some residents, some surgical residents, and they asked for something like this. So we put the sheet together for this so that it would help them determine what kind of device that the patient would get and the outcome of the patient with the device.
Perfect. Now they can see my mouse move.
Okay.
So if you want to take control and kind of talk through what's what.
Okay, so basically for an MCP driver, which the next couple slides you'll see, I'll show all these things to you, but MCP joint would be right here. So if they had a really short MCP joint and did not have where they had good range of motion and didn't have very much flexion or enough limb left for the ring to stay on, then the MCP driver would not work. So that's what that red is for right there. So it would need to be up in this area here. Same thing with the PIP joint. That isn't the best area for it. Doesn't mean that we can't put something on them, but for the MCP driver and PIP drivers, that's not really the best spot. You would want it out in here and make sure that they have flexion, extension, good range of motion. So go to the next one.
All right. So now, keeping this in mind, we're going to jump into devices, and I'm going to let Mike kind of go through the pros and cons of each.
So PIP driver, you can see how it flexes. These devices are very durable. They have to be amputated after the PIP joint and have range of motion. So back to that slide, we're not going to go back to it, but the slide that was there, they have to be able to bend there and have enough limb left to activate this device. So it's very hard to do this with your finger, but you can see how this curls around then. Okay.
So that is considered a body-powered or body-driven prosthesis, and it's very voluntary. So the user, the patient, has direct input in the outcome or the function of that device and the range of motion it goes through.
Yeah, so the patient is really doing this exact same thing they were doing for flexion and extension on their finger. They're doing the same thing. These devices are very strong. I don't know that we've had anybody break a PIP driver before. You can get them dirty. You can get them wet. The cons to these they are very mechanical looking, as you can see, and they do have different colors and different styles, like this. Okay, and then this one's the carbon fiber look right there. This one is, I don't know what color it is, but it's tan. Okay. And then, so the other con to it is if the device, or if the amputation level was too short, then they wouldn't be able to use one of these. But if they did have that happen where the amputation was too short or they didn't have good flexion extension, then they have a fixed one like this. So what we would do is take this and have the angle that the patient needs built into this, and this one does not articulate then. So they would just put that on and they would use the MCP joint. It's very hard for me to do that, but they would use the MCP joint to drive this, is how that works. Okay, so there is an option if it's not the limb length that we would prefer, there still is something else out there for them.
Candace, I see that you rose your hand. Great. If you have a question, if you would be so kind, type it into the chat, only because I'm not able to unmute your mic. So if you type a question into the chat, we'll be more than happy to help you out. And this is fun. We didn't have prompts the last two presentations. I like this a lot better. I feel more interactive.
Nice. So. Well, good. I'm glad.
I'll throw one more thing in there as well while we're waiting for that question. So this device, as you can see it going on and off there in his finger there, kind of fits similar to a ring. And that's how, from a clinical perspective, we're fitting these patients. We have different ring sizes and different shapes, one that's more oval and one that's more round based on kind of the profile of that finger or that digit. And that's essentially how we're also suspending the device. So why Mike keeps mentioning the length of the limb, you have to kind of envision a ring going up onto that finger that's left, and not only being secure through all ranges of motion, but also, we take things into account such as volume or swelling, and there are some adjustments that can be made to that prosthesis as a result of that. But as you imagine, as any amputation occurs, that volume of that limb or that finger in this case can fluctuate and change. Similar to anyone who's worn a ring before may have to go through process of having it resized or adjusted to make sure that it's not essentially falling off of them. So in this case, obviously, this is a prosthesis that if it were to be falling off, you can imagine how that's going to affect the patient wanting to wear the device, as well as kind of how functional this device appears or is to them for them to actually get, the outcome that we're after.
So our friends who attended last Thursday learned about prosthetic socks in the lower extremity world. Is there an equivalent for partial fingers, or what's the plan there?
Well, we'll just show you for this. If you can see, there's a set of holes inside this, and then I believe on that side too. Okay, so these slots right here are for the rubber shims that you would put in there, and you wouldn't put them in, we would put them in, but the rubber shims, they just come in different thicknesses and they just pop inside there. So if the device fit well the day of delivery and 4 months later it was a little bit looser, then we can put a shim inside there to tighten it up to make it function properly.
Perfect. And Candace actually just said that we answered her question about fit. And by we, I'm sure she means me.
Okay.
All right. Cons on this guy.
We did those.
We did the cons. Okay.
So you can go ahead and go to
Good
the video.
These are the videos that you can find on that YouTube playlist. And we're going to watch someone cut up chicken for 6 minutes straight, because this one's just a touch longer.
So as you can see right away from this video, this patient has numerous devices that they're wearing, and that can be said for just about any partial hand amputee. Is a lot of times it's not just a PIP driver or a MCP driver. Sometimes it's a combination of the two that they utilize to achieve different grasp or different functions to kind of restore that partial hand amputation.
Friends are already identifying that plate. This is where we love making friends with OTs, as finding what other devices around the kitchen can help out.
So as you can see, what she's doing here with the PIP drivers is using them for typing, and it's those devices. It looks like one of those does not articulate. I'm thinking that one doesn't articulate, but maybe it does.
She's going pretty fast.
You can do it with either one for typing. If your device did not articulate, you can use the one that does not articulate, because you would just be using your MCP joint then. That would be one where we would measure and get the right degree of flexion so that it worked best for the keyboard. We would get that figure out once we send it in to have it be made.
All right. We're going to move on to MCP driver.
Okay, for MCP drivers, you have to have it's basically the same thing. You have to have range of motion after your MCP. So this ring right here, that ring would have to fit on your finger. So it's going to be inside all the way back to there. Okay, that's where that's going to be. So they have to have flexion and extension there, and they have to have enough left for that ring to fit on. Okay, and how this device works is the same thing. They would just flex their MCP joint, and this would curl around just like that. Okay. So very durable devices. I'm pretty sure on the brochure it shows somebody having these on all four, maybe even the thumb too, and they're carrying hay bales. So I would say that whatever your finger can handle picking up your residual limb, this would be able to take care of it. I don't think we've had anybody break the bars or anything like that with these either. So same as the other one, it would be you're still moving the MCP joint just as you did before to flex and extend your finger. So it works the same that way. Cons would be the same as the MCP joint. It's not cosmetic. It's not very cosmetic. It's mechanical looking. And if there isn't enough limb left on there, then the ring would not stay on their finger. So as soon as they flexed and when they extended back up, the ring would end up coming off of the finger is what would happen. It's very hard to do with your finger.
I know, I'm just going to put I'm trying to bend my finger down so that, there we go.
So one thing that you see Theron doing as well is the suspension of this device isn't only the ring that's going on the finger. You see there's a strap that actually typically goes around the wrist as well. And that kind of helps position the MCP driver as well in line with that digit.
And it would be back further on his hand, but because he can't get the ring back far enough because his finger's in the way.
Make it work.
Yeah, you'll get that stuck on me.
So one thing to keep in mind as well, I already mentioned some of the things that we have to take into consideration based off the volume of that digit with fluctuation. Another thing that we ran into as well, Mike can speak to this, is we've had a patient who's actually thankfully improved in range of motion, but as they improve in range of motion, that bar, that linkage on the back of the hand was actually contacting like his knuckle when he was flexing that finger. And there's some adjustments that can be made. I'll let Mike speak to those closer if that were to occur. But I think in this case, it was such a change in range of motion where we had to have a new device fabricated and made for the patient based off of that improvement.
Yeah, which is great for the patient because I believe they were their flexion range was at like 74 when we put the device on them, and probably 7 to 8 months later, it was 100, I think 110. Okay, so big difference, and just by having the patient wear it and use it at work, which is what he did, and it definitely helped him. So the adjustments are same thing here. You can see where you put the rubber shims in those two holes, and then this piece here can be adjusted back and forth right here. So we would get that set, and then this gets adjusted too. So if that does take place where they're getting more range of motion, we can adjust. But that patient just definitely got up quite a bit more range of motion, and it made it so he had to have a new one, which was fine. The insurance still covered that. That's actually a really good thing. He did go to therapy and use it at therapy for, I think, two months maybe. And then being on the job actually helped too.
Was this the friend that I just filmed recently?
Yes.
Yeah. So
Yes.
if you guys, I wish I had time. I was going to put it into this PowerPoint, but I literally just posted it yesterday. So the YouTube link that I sent you guys with these videos, it's a playlist. And so what would probably be the last video on the playlist is a gentleman who has one of these devices.
Does he got two?
Nope, he's got one.
Nope. So
different guy. Okay.
Different one.
Still
Different one.
But still, the video that I'm thinking of is a patient who was just recently delivered it 3 weeks ago, and he uses it at work to pick up. How big were those?
The totes. It was either 20 or 30 pounds.
Yeah, so they're not small things, and when you lift hundreds of them a day, your fingers get very sore, and so he basically said it was life changing.
Yeah.
So I do invite you guys to check out that video. But in the meantime, we're gonna check out some other patients.
I'd say one of the things that stood out to me when I was first learning about these devices, because I think all in all, in terms of kind of the prosthetic world and the advancements that have been made in them, this is definitely one of the newer designs or options for patients. Not that they're that new, but again, in the big picture, they kind of are. Would be the amount of dexterity that the patients are gaining and some of the precise things that they're doing, such as cracking an egg or typing on a keyboard, and just all these different scenarios and different activities that these patients are able to do in terms of getting their life back and getting function back. I think anybody can understand after having some exposure in the prosthetic world how some devices don't do a whole lot of jobs maybe, or there's a device that's better for this versus that, where this is a device, or these devices are ones that really kind of cover a lot of ground and what the patient's wanting to do, and again, everyday life and at work.
Yeah, most people can't use chopsticks.
I can't use chopsticks.
What's the terminology we use, Mike? One thing comes to mind when we're, looking at amputees that are transradial, transhumeral, where obviously terminal devices and things like that are
Tools.
Are a tool.
Everything's a tool.
Yep.
Yeah.
And there's not one tool that does all jobs, and that's the case for anything in the prosthetic world. But this is essentially a tool or a prosthetic device that really does quite a bit.
Absolutely. All right, gents, anything else on MCP before we move on?
I think so.
All right, we're going to take a look at the thumb driver.
Okay, so thumb driver works very similar. It's just like the MCP driver. Okay, so they just have to have enough range of motion right there after or before that joint there to get this to activate. So it works as the same as an MCP driver. Okay, it does the same strength as far as what it will hold as the MCP drivers. And for the cons, they're all the same, really. It's a mechanical looking finger. And if the surgical length is too short, then they won't be able to use this. And this ring is adjustable just like the MCP joint is, just like that. Same with this top piece here. That's adjustable. I think that's it there if you want to play the video.
All right. Mike, anything from your perspective on the thumb driver?
Nope, I think that pretty much covers it.
So we all know how much the thumb matters on the hand. To get your thumb back, that's huge. And these devices definitely will give the patient that back as long as they have enough length and range of motion. It works great. And with these devices, you can have 2 MCP drivers and 2 PIP drivers on your hand and a thumb driver. It can all be mixed together.
All right. Moving on to grip lock.
Okay, so for the grip locks, we don't have any of those here to demonstrate how that works, but that's a ratcheting finger. So they have half fingers, they have full fingers, but the ratcheting finger, the way that it works is it's built into a socket that goes around your hand. It's very similar to this one right here. So this is a socket that goes on somebody's hand where they still had their thumb. Okay, so it's like that. But the ratcheting finger, when it goes down, it just clicks. So it'll stay put where the patient puts it. You don't have to use your other hand. You can run it into a table or something to get it flexed, and that's where it would stay. I think it handles up to 70 to 80 pounds is what it would take. There is a release button on that, as you can see on the back side right there, that black portion, yep, right there. That's what would let it go back up to an extension. So if the grip lock finger was extended all the way, and let's say they had a broom handle inside there, then they would have to push the button to get that to extend back up. But if they didn't have anything inside there that was tight, you can push further, you can flex it further, and it will spring load back up. Those are the same as the PIP drivers and MCP drivers. You can get those wet. I don't believe we've seen anybody break those either. They're very durable too. The cons to those is it's not really body power driven. It's you have to use your other hand or something to push into them to get them flexed and extended, or use your other hand. And it definitely is mechanical looking.
All right. Perez, anything on these guys while I play this video?
In that last picture, that patient was wearing an MCP driver as well as the grip lock fingers. And I've seen, again, at the eval where we're kind of basing this off of the patient's activities and what they're wanting to do at work or everyday life. You know, we mix and match these devices together. And I'd say that's a little bit of a difference versus a PIP and an MCP driver together because of the way that they function and how some are voluntary or body driven versus these ones are kind of manually positioned, which is what he's showing you here. He's got that exact scenario.
So you see the style of socket that he has. They either have those Velcroed on, there's a Velcro strap on the side here, or they have a zipper. That one looks like it has a zipper on the side. And that's how they donned off the prosthesis.
Very cool. I will take a time out here because I've noticed how, and we do talk about this at more length a little bit later, but in terms of cosmetics, what's your typical when you have somebody coming in who's like, weighing the cosmetic side of things versus function, right? Because I know we've had some patients who were very gung-ho coming in until they laid eyes on these things, right? So what are those conversations like?
Well, I mean, most people do want function back. I would say most of them would prefer function over. If they have to choose between a silicone device or something mechanical looking, most of them would take the mechanical looking versus the silicone device. It's not that the silicone device doesn't provide you with function, because it does. You can still hold things with it. But the other part of that is getting insurance to pay for a silicone device is not really the easiest thing to do. We have done that, and sometimes we can get that to go through, but a lot of times when insurance sees silicone in there, they just don't want to pay for any of that stuff. That answer your question?
It does. Mike, anything else to elaborate on that?
Nope, I think you answered that pretty well.
Perfect. All right.
Okay, so now we're going to go to iDigits, Access, and Quantum. So basically, these are electric fingers, is what these are. And here's a battery pack that would be on their forearms. So it would be back here on your arm like this, and it velcros, and these batteries wrap around. They wrap around your arm like that. This patient still had their thumb, and this would be just a strap that would run across here. And the way that they would activate this device is the electrodes are going to be right here. And when they do pinky down, that's going to close the fingers. And then the other electrodes would be right here. When they bring these two together, activates this muscle, and that's what opens the hand. Okay, so I can demonstrate this thing working here. And this is something that's connected to a laptop. How this is working, I'm just sticking my finger inside there and tapping on the electrodes to make it work. But that's what it does. Okay. These fingers have 15 pounds of pinch force. The batteries, they get 4 batteries. They last 6 hours. So they will have to change them if they wore this all day. This cannot get wet. I mean, if you were outside and if you had to walk to your car and it was raining, that's okay. But you wouldn't want to sit out at a ball game where it's pouring down rain. You'd want to take this off or put something on to cover it. It can be 1 digit, 2 digit, up to 5, doesn't matter. This can be combined with a body powered device too. They're normally made out of silicone. This flexible Perez, it's made out of silicone. And they do that for comfort and fit purposes. The cons to this is it's non-intuitive, and the batteries only last six hours, but they do give you 4, and then it's also not waterproof. Okay.
Mike, tell me a little bit about how those fingers operate. So obviously you got the electrodes in there, and those are placed specifically by us inside the socket. With the PIP driver, they're just essentially still doing this. An MCP driver. How do these function?
I'm not sure what your question.
How do you achieve open and close on that device?
Oh, that's where the electrode, they said that. So this one here would be, electrodes are right here. So it's pinky down, and then it will close. And then right here, we put 2 electrodes right here. And when you bring these 2 fingers together, that's what would open the hand.
There's a lot of time spent in therapy kind of learning how to isolate those muscles. You'll say relax 1,000 times, trying to get there not to be interference and for those signals to be clear, so that partial hand or that iDigit understands essentially, what is this patient trying to tell me what to do? Am I trying to open or am I trying to close?
And we would also send somebody to pre-prosthetic training for this too, because it helps whenever the day of delivery. It will help the patient with being able to open and close this. And then we would send them back after they get the device too.
So that's part of the evaluation as well. That was on that slide. It stated myo testing. So there'll actually be a myo buoy or a device where we can actually assess essentially that patient's ability to send that signal and what strength is that signal to operate this device, and then get further training in OT.
So that device connects to an iPad to a program where the electrode gain can be raised and lowered, so can the threshold. So some patients have better signal, better a higher EMG signal, so they would be turned down for them. If somebody had lower EMG signal, then we would turn it up. That's all stuff that we would come and train the therapist with using this device and get them the program, so that way they could help with the training on this too.
Perfect. All right. Moving on to M fingers.
Okay, so M fingers, the way that the M fingers work, I don't have that for a sample here either, but the way that the M fingers work, the video is going to show you quite a bit, but they just use wrist flexion. So when they flex their wrist, it brings the fingers into flexion too. So there's a little dial right here that the patient turns, so they can either have their hand like this and it would flex the fingers with their hand being straight, or they can loosen it so that way their wrist would be flexed too, and then it would flex them down here. Okay, so that's all adjustable for the patient. They do work well, except for the fact that you're using wrist flexion extension, but sometimes that's the only thing that there is. So the amputation level is going to be at MCP or lower, is where when the patient would get this. I typically would not recommend putting this on anybody that's an adult, because the grip strength is not very good for these. But for a child like this young lady here is, you'll get to see that in the video. It does really well for her. And durability, that's why I would say I would only put them on kids too, because they're just not as durable. But whenever you have somebody that has that amputation level in a small hand, these are very good for the PTs.
All right, let's take a look at Caitlin here.
So you can see the dial on there when she sits down. You see the little dial on there. The thumb is friction, so it can be tightened to where it would just stay in place then. Yep, and it does flex and extend. And it rotates.
Pause it so you can kind of see. There's a good shot of that dial. Is that dial right there?
Nope.
Go back up.
A little bit. Yeah, go back some more.
Sorry, folks. I'm trying to show you that dial. There you go.
It's that dial.
Right here.
It's right there. Yep. And it's a really quick adjustment. They just turn it a little bit and it loosens the cable that goes to the hand very quickly. So that way they can either flex more or extend more to get the fingers to close.
Right. All right, Mike, talk to us about some therapy goals.
Absolutely. So there's a lot of different areas, and a lot of these are patient dependent, obviously, but as we mentioned earlier in the presentation, we had an individual who had poor range of motion, and by working in OT and getting back to work, they improved in their range of motion. That's just one kind of real world example that we've experienced with these devices. But certainly you're getting these patients back into everyday life and working. And we're going to be working directly with the therapist, as Mike already mentioned, to try to achieve some of these goals, but looking at range of motion, strength, and essentially for them to apply these devices into real world scenarios. Early on, it might be some different goals, such as picking up and moving blocks and working on dexterity, and the eye digits come to mind when you're working on EMG signals and strengthening those signals. But essentially the big picture leads into utilizing these devices and improving wear time and improving compliance and making these as functional as possible. That's essentially the end goal. One thing that hasn't been mentioned yet is how much this prosthesis or these devices can play a role in kind of the patient's mental block of where they're at with coping with this loss, and what this means socially for them, and being able to go back out in the community and live life and do different activities outside the home, not just functionally, again, but emotionally, it plays a big role there as well. So, again, we're kind of working to team up with therapy to help work towards some of these goals, and assist in any way that we can throughout the process. Because providing somebody with a prosthesis is great, but if they're not getting to where they want to be in terms of the goals and back into life and what we envision this being utilized for, it's kind of a failure or not the outcome that we're after. So we acknowledge that we're one part of the picture, and we want to team up with everybody else that makes the picture whole and get the outcomes that we're after.
Perfect.
All right. And then the last chapter, I'll let either of you decide to jump in on this, but talking about that big elephant in the room.
Go ahead, Mike.
So I'd say, again, kind of going through the evaluation process and evaluating what's available for patients based on how they present. It can be challenging if the amputation site or level isn't ideal. So in some cases, it's rare. I'd say it's not something that we run into often, but in some cases, a revision surgery is ideal or needed, in our opinion, to get the best outcome or to be able to fit that patient with a device that's going to give them the best outcome. I think we actually have one scenario in process right now that kind of is right along those lines of the patient going back and having a revision done to get fit with a better prosthesis and be more functional and get better outcomes in terms of what life is going to look like in the long run in terms of everyday life and work as well. So we definitely approach that decision with the patient and definitely get family involved. And certainly, obviously, after these discussions happen, we get in front or with a surgeon and kind of talk about the game plan and why this decision's being made. And then the backside of it, obviously, is then a new evaluation and getting the insurance to understand what's being done and why to have this new prosthesis approved. COAP would be another example of that. I know we don't touch on that in this presentation, but those are some just examples or scenarios of sometimes what that big elephant in the room can be. Anything to add, Mike?
No, I think that covered it right there pretty good. If anybody has any questions, we can go over the questions.
All right. Mike, while we're waiting on those questions, I do have one because you treat both lower and upper. What are the biggest differences psychosocially? Because you kind of emphasize that a little bit. Do you see it's a bigger, more elaborate conversation in the upper world, or does it just depend on the patient?
I think it depends on the patient for sure. I mean, that can be said for any scenario or any patient, and how you're going to approach kind of that conversation or their care. But personally, I'd say I kind of approach it the same way in terms of upper and lower. There are a lot of studies and information out there, and then we actually share this with the insurance when we're looking at getting something approved, that there's actually studies and information out there that shows that a patient actually suffers more in terms of emotion and cognitively and psychosocial when dealing with a partial hand or an upper extremity amputation. So there is information out there that shows that that's the case, but really any amputee is going to be dealing with a different form of loss or could be handling being an amputee a little bit differently. So we always address that very early on.
And then one other thing that we did mention whenever we were on the eval screen, if we do a consult or an eval, if we're called to do that, we don't have to have a script for that. We can come out and do that, and there is no bill. We don't bill for any of that stuff. The billing is only if we provide something for somebody. So a consult or an eval doesn't cost anything. We would come out to, we'd go to the hospital or we'd go to therapy to do that, or they can come and see us, either one.
That's a great kind of bookend to remind you guys, just call. When you get your certificates from me, there'll be contact information at the bottom. Consults are free. They're very low pressure. We just want to answer questions and talk about their goals. And if we can connect them to a patient who's gone through something similar, that's win-win for everybody, because our patients then have the opportunity to pay it forward. The gentleman who you'll see in that video, if you go to our YouTube channel, was elated at the idea that he was going to help the next guy, right? Because then when these guys go into consults in the hospital, they're going to bring an iPad or a phone and they're going to show them that video to see what life is like. Because for a lot of these folks, they just sit there, and if you're anything like me, you sit there in the hospital and you just research, and if you don't find what you're looking for, it can weigh on you a little bit. So we want to be able to provide appropriate resources for our patients.
We always like to operate under the understanding and feel firmly that the sooner we can get in front of the patient, the better, from the time that they've had their amputation, so that we can provide education, we can provide that support. At the very least, we can provide some hope that, you know, there's options out there, and there's proven outcomes in situations like Darren said. We can get them in touch with another patient of ours who been through this experience and they've lived it, and they're back into life. And, you know, just because they've had an amputation doesn't mean they can't do X, Y, Z. It might mean that they're going to do it a little bit differently, or they have to approach it differently, not only physically, but mentally, but it doesn't mean that they can't.
Absolutely.